Patient's here.
Oh boy, got some blood going.
Yeah, there's blood.
Oh, he's wearing it too.
Welcome to the bed. When you get over to the bed, we'll go ahead and give you the story. This is all going to happen super fast. Welcome to the emergency room.
70-year-old female, single driver of a vehicle, appears that she went off-road into a ditch, rolled over her car into a tree, caved in, the top of the vehicle was caved in, so she was hanging out partially from the window. She's been in application
in your left hand.
for 45 minutes of CPR.
We can stop CPR with 600.
Welcome back to the Deep Dive. Today, we are tackling a topic that I think a lot of people, even seasoned clinicians, tend to underestimate a little bit. It's so easy to dismiss it as, just sniffling kids and a bit of pink eye.
Right, the bread and butter stuff.
Exactly. But when you are actually standing there in a pediatric clinic, or maybe you're a nursing student staring at a crying toddler who is just clawing at their ear, you realize this is a beast of a topic.
It is.
So today, we are diving into the pediatric sensory system. Specifically, we are breaking down what our sources say about sensory perception and disorders of the eyes and ears.
And it is a massive topic. You're totally right. The underestimation factor is real. I think people think, okay, eyes and ears, antibiotics and glasses, done.
Yeah, problem solved.
But when you actually dig into the source material, the textbook chapter, the lecture slides, the drug guides, you realize we aren't just talking about treating an infection. We are talking about protecting the actual architecture of a developing brain.
That is the angle that really grabbed me when I was prepping for this, that we aren't just mechanics fixing a broken part.
Yeah.
We are safeguarding how a child learns to exist in the world. So for our listeners, whether you are that nursing student who is terrified of the boards or a clinician wanting to sharpen your assessment skills, that is our mission today. We are taking this mountain of material and stripping it down to the Pareto 80-20.
The vital few.
Yeah.
That 20% of the material that answers 80% of the exam questions and, critically, keeps these kids safe from permanent developmental harm.
Exactly. We have a lot to get through. We've got the textbook chapter, lecture notes, the drug guides. We're going to map this out logically. First, the master 80-20 map, the anatomy patterns that basically dictate destiny. Then a deep dive into the ear complex, the whole soup to nuts of otitis media. After that, the eye complex infections, trauma, and the silent killers of vision. And finally, we will synthesize it all with the developmental so what.
Sounds like a plan. And I just want to emphasize that point about development again. In adults, sensory issues are often, they're an annoyance.
Right, a huge annoyance, but you get through it.
But in children, they can be a developmental emergency. It's a completely different ballgame.
Okay, let's start right there then. Section A, the master 80-20 map. You mentioned anatomy is destiny. When I look at the statistics in these documents, the sheer volume of ear infections in children compared to adults is. It's just staggering.
It's not even close.
Not even close. So why is that? What is the structural flaw in a child's head?
Well, it's not so much a flaw as it is, a work in progress. It really all comes down to the horizontal tube concept. This is the absolute cornerstone of pediatric sensory anatomy. If you look at the figures in the source material, they do a great job comparing the adult eustachian tube to the child's.
I'm looking at one now. The adult one looks like a nice steep slide. The child's looks, it's functionally flat.
Exactly. In an adult, the eustachian tube angles downward at about, 45 degrees? Gravity is your best friend here.
Okay.
It helps drain any fluid from the middle ear right down into the throat. But in an infant or a young child, that tube is shorter, it is wider, or critically, it is positioned almost horizontally, maybe 10 degrees. It's a nearly straight line from the nasopharynx to the middle ear.
So instead of a slide for drainage, you've got a hallway.
A hallway that is, extremely prone to flooding. And there is a nuance here that the text mentions but often gets kind of glossed over in lectures. The muscle function.
Oh, interesting.
In adults, the tensor veli palatini muscle actively opens that tube when you yawn or swallow. That's what gives you that pop on an airplane.
Right. It equalizes the pressure.
It equalizes the pressure. In infants, though, that muscle is functionally immature. It's floppy.
Floppy.
So not only is the tube flat, meaning gravity can't help drain the fluid, but the mechanism to manually open the door and let air in is also incompetent. It just doesn't work right yet.
So you have a tube that won't drain and a door that won't open.
Precisely. and that creates the absolute perfect storm for negative pressure. When that tube stays closed, the air that's already inside the middle ear gets absorbed by the mucosa.
Okay.
That creates a vacuum. And what does a vacuum do?
It sucks.
It sucks fluid right out of the surrounding tissue and into that middle ear space. That is how you get fluid accumulation without even having an active infection yet. It is purely a physics problem caused by that flat anatomy.
And then on top of that, you add the fact that kids are basically germ factories.
Right. I mean, their nasopharynx, the back of the throat, is just teeming with bacteria and viruses because kids are constantly putting things in their mouths and getting colds. Because that tube is so short and horizontal, it acts like a superhighway for pathogens. Bacteria don't have to climb a hill. They just walk right across the hall from the throat to the ear.
This explains so clearly why the recent upper respiratory infection is such a massive risk factor on every exam question about this.
It is the #1 precursor. You get a cold, the adenoids swell up, which, by the way, blocks the tube even more, and then the bacteria just migrate. It's almost a mechanical inevitability in some kids.
Okay, so that's the ear anatomy pattern. The horizontal tube is the villain. What about the eyes? Is there a similar structural destiny going on there?
With the eyes, it's less about plumbing and more about the neurological trajectory. The key concept here is really use it or lose it. The sources all emphasize that visual acuity is not fully developed at birth. Not even close.
I was actually surprised by the numbers in the text. It says babies are essentially legally blind at birth.
They are. A newborn's visual acuity is around 2400. They can see shapes, they can see high contrast, which is why those black and white mobile toys are so popular.
Right.
But they cannot see detail. The brain hasn't learned how to process a sharp image yet.
So the hardware is there, but the software is still downloading.
That's a fantastic way to put it. And that download process takes time. We expect them to reach 20/20 vision by about age 5 to 7. But, and this is the critical but, that software installation only happens if the brain receives clear, focused images from both eyes during those critical first few years.
This is leading us straight to the concept of amblyopia, right? Lazy eye.
Correct. Amblyopia, or lazy eye, is the consequence of interrupting that download. If anything blocks or blurs vision, a cataract, a droopy eyelid, or the eyes being crossed, strabismus, before age 7, the brain literally stops trying to process the image from that eye.
It just gives up on it.
It's a matter of ruthless efficiency. If the brain is getting a blurry image from one eye and a clear image from the other, it views the blurry one as noise, as static.
So it just tunes it out.
It suppresses the neural pathway. It effectively hits the mute button on that eye to avoid double vision.
And the scary part, which the texts really emphasize, is that you can't just unmute it later in life.
Exactly. In an adult, if you patch an eye for a week, you take the patch off and you see fine. In a child under 7, if you block clear vision for a significant amount of time, the neural connections literally atrophy. You can cause permanent blindness in that eye because the brain development just halts.
Wow. That really raises the stakes for those early vision screenings. We aren't just checking if they need glasses, we are checking if their brain is still connected to their eye.
That is the 80-20 takeaway for eyes. Vision is a developmental race against time. If we don't fix the structural issues by school age, that window closes. Maybe not completely, but it gets a lot harder.
All right, let's move into our section B, the system by system lecture. We are going to start with the ear complex. This feels like the bread and butter of pediatric nursing, but the terminology can feel like that alphabet soup. We have AOM, OME, OE.
It is alphabet soup,
Yeah.
but you absolutely have to know the flavors. The exam and your clinical triage in real life relies entirely on distinguishing the angry ear from the full ear, from the swimmer's ear.
I love that framework. Okay, let's break those down. The angry ear, that's AOM, right? Acute otitis media.
Right. AOM is the acute infection. This is what parents mean when they say, my kid has an ear infection. Pathologically, you have fluid in the middle ear, that space behind the eardrum, that is actively infected with bacteria or a virus. The key identifiers here are rapidity and pain. It comes on fast.
So tell me what this kid looks like. I'm in the clinic waiting room. What am I seeing?
You see a miserable child, just inconsolable. Might have had a cold for a few days, a little runny nose, and then suddenly they're spiking a fever.
Yeah.
They're crying, they're irritable. If they're an infant, a pre-verbal kid, they might be rolling their head from side to side or pulling at their ears.
Okay.
And critically, they might refuse to lie down. This is a big one.
Because lying down increases the pressure.
Exactly. When they lie flat, vascular engorgement and the fluid shifts, increase the pressure in that tight middle ear space. It hurts more. So they want to be held upright on mom's or dad's shoulder.
Now, I grabbed the otoscope. What am I looking for inside? What's the classic sign?
You are looking for what I call the angry donut. A normal eardrum, a tympanic membrane, is pearly gray. It's translucent. You can kind of see through it. And it's concave, so it curves inward slightly.
Right.
In AOM, it is bulging. It looks like it's about to burst out towards you because of all the pus pressure behind it. It's bright red. It's opaque, so you can't see through it. And you can't see the normal landmarks, like the handle of the malleus bone. They're gone.
Okay. Bulging, red, painful, fever. That's AOM. Now let's contrast that with OME, otitis media with effusion. You called this the full ear.
Right. So think of OME as a plumbing clog, but without the fire. There is fluid in the middle ear, just like in AOM, but it is not infected. It's sterile. It's usually serous fluid, so thin, watery, or maybe a bit mucus-like.
So does it hurt? Is the kid still miserable?
Usually no.
Yeah.
And that's the tricky differentiator, especially for parents. The child isn't screaming. They aren't febrile. They might complain of a popping sensation or a feeling of fullness, like being underwater. But they're eating, they're sleeping mostly okay. It's much more subtle.
And visually, what does the eardrum look like then?
The eardrum won't be bulging and red. It will look dull, grayish. It might even look retracted, sucked back because of that negative pressure vacuum we talked about earlier.
Okay.
And often, if you look closely, you can see a fluid level line or little air bubbles behind the eardrum. It literally looks like a little fish tank in there.
Bubbles and dullness versus bulging and redness. That is the exam differentiator right there.
100%. If you
Yes.
can see bubbles, it's OME.
Yeah.
If it's bulging and you can't see anything, it's AOM.
And then the third one, OE, otitis externa, the swimmer's ear.
This one is completely different because it's not behind the eardrum at all. It is an infection of the skin of the ear canal itself, the outer ear.
Okay.
It's usually caused by water getting trapped in there after swimming, which changes the pH and allows bacteria like Pseudomonas or even fungi to grow.
And the test for this is all physical, right?
Yes, the tragus test. This is your go-to. If you wiggle the earlobe, the pinna, or you push on that little flap of cartilage in front of the ear canal, the tragus, and the child jumps through the ceiling, that is otitis externa.
Why is that differentiation so important?
Because a child with a middle ear infection, like AOM, usually won't care if you wiggle their earlobe. The infection is deep inside, protected behind the drum. But for OE, the skin of the canal is so exquisitely inflamed that any movement is excruciating. So if you touch the ear and they scream, think external.
That is such a crucial need to know. So simple, but so effective. Okay, let's talk about management. We have to address the elephant in the room, antibiotics. The source material is very clear about the wait-and-see approach for AOM.
Or watchful waiting, yeah.
Right. But I'll be honest, if I'm a parent and my 2-year-old has been screaming for 6 hours straight and you tell me to wait and see, I am not going to be a happy camper.
No.
I want the pink stuff. I want the amoxicillin. Now,
It is an incredibly difficult conversation to have. It's one of the hardest parts of pediatric primary care. You are essentially telling a parent, I see your child is in pain, I know there's an infection, and I am going to choose not to attack it with drugs yet.
it feels completely counterintuitive.
Yeah.
Why are the sources and the American Academy of Pediatrics so adamant about this? Is the risk of the drug really higher than the risk of the infection?
That's the critical question, isn't it?
Yeah.
And the data suggests that for a huge percentage of these kids, specifically those over 6 months old with uncomplicated, non-severe AOM, the body clears the infection on its own within 72 hours at pretty much the same rate as it would with antibiotics.
Really?
Yeah, many of these are viral to begin with, or they're just self-limiting bacterial infections that a healthy immune system can handle.
So the drug isn't actually speeding up the cure in many cases.
In many, many cases, no. But the side effects of the drug are guaranteed. Diarrhea, rash, potential allergic reactions, and the big global threat antibiotic resistance.
Mm-hmm.
If we prescribe amoxicillin for every single red ear, we burn through our first line of defense. We create superbugs.
But there's a safety net here, right? We aren't just sending them into the wilderness and saying good luck.
No, absolutely not. And that's the SNAP protocol that's mentioned in the slides, the safety net antibiotic prescription.
Okay, tell me about that.
You give the parent the physical prescription paper or send it to the
Okay.
pharmacy, but you say, don't fill this until Friday. Give the pain medicine, use a warm compress. If he isn't significantly better by Friday morning, then you fill it. It puts the power back in the parent's hands while still adhering to good antibiotic stewardship.
That makes a lot of sense. But there are exceptions. Who gets the drugs immediately? No questions asked.
Babies under 6 months, we don't gamble there. Their immune systems are too immature, and the risk of sepsis is higher. Also, Any child of any age with severe symptoms, so a high fever over 39 Celsius or 102.2 Fahrenheit, severe pain, or a bilateral infection in a young child, they get treated immediately. No waiting.
Okay. Now, what about the kid who has chronic fluid? The OME that just will not go away. We see this term PE tubes all the time.
Tympanostomy tubes, yeah. Or pressure equalizing tubes. If a child has OME, that non-infected fluid that lasts for more than 3 months, or if we document any hearing loss associated with it, we start considering tubes.
I think there is a misconception out there that these tubes are just drains, like you're putting a faucet in the ear to let the gunk out.
It is a common thought,
Yeah.
but actually they're primarily pressure equalizers. That's what the PE stands for.
Right.
You know, that horizontal floppy eustachian tube that isn't working?
Right.
The PE tube acts as an artificial eustachian tube. It's a tiny little grommet that sits in the eardrum and allows air to flow into the middle ear from the outside. By equalizing the pressure, it prevents that vacuum effect that sucks the fluid in the first place. It ventilates the ear.
That makes so much more sense. It's not draining fluid out, it's letting air in.
Exactly. It stops the fluid from ever accumulating.
And what do we tell parents about these? Because they are tiny pieces of plastic in their kid's head. It can be a little scary.
The biggest teaching points are, 1, they fall out on their own, usually in 6 to 12 months as the eardrum heals. Parents shouldn't be alarmed if they find a tiny little school in the earwax one day.
Okay.
And 2, water precautions. The source material is a bit nuanced here, and surgeons differ, but the general consensus is if swimming in dirty water, like a lake or a non-chlorinated pond, they should wear earplugs. We don't want lake bacteria getting a direct route into the middle ear.
What about bath water?
Bathwater and chlorinated pools are usually considered fine without plugs, but parents should always follow the specific instructions from their ENT surgeon.
Okay, that covers the medical side. But I really want to pivot to the developmental impact, because you mentioned this earlier and it's so important. Why do we care so much about OME, that fluid, if it doesn't even hurt?
We care because of hearing. That's the whole ballgame. Fluid in the middle ear muffles sound. It causes a conductive hearing loss. It's like listening to the world while wearing heavy earmuffs or with your head underwater.
And if you were a 30-year-old, that's really annoying for a few weeks.
Right. But if you are 18 months to 3 years old, you are in the prime critical window for speech acquisition. You are learning how to articulate those high-frequency consonant sounds, the Ts and Ss and Ks. If you can't hear them clearly because of the fluid, you won't learn to speak them clearly.
So the red flag here is a speech delay.
A huge red flag. If you have a toddler who has a history of frequent ear infections, or you suspect chronic fluid, and they aren't talking, or their speech is unintelligible to strangers, or maybe they even stop babbling, you need a hearing test immediately.
It's not just, oh, he's a late bloomer.
It might not be. It might be he literally cannot hear the data he needs to learn.
Wow. That connects it all perfectly. The anatomy causes the fluid causes the hearing loss causes the developmental delay.
And that is the 80-20. You diagnose the delay to find the fluid to fix the ear to save the development. It's a chain reaction.
Okay, moving on to topic 2. Conjunctivitis, pink eye, the bane of every daycare center's existence.
It is highly contagious and incredibly common. But for the exam and for your clinical triage, it is all about the discharge. You have to become a connoisseur of eye gunk.
Gross, but absolutely necessary. Okay, let's play the differential diagnosis game. I'll describe the eye, you tell me the type.
Let's do it.
Okay, scenario 1. A 4-year-old wakes up and his eyes are completely glued shut. There is dried, crusty, yellow stuff all over the lashes. When you wipe it away, there's more thick, white, or yellow pus coming out. One eye started yesterday, and now both have it.
That is classic bacterial conjunctivitis. The key words are purulent, meaning pus glued shut or crusted in the morning, and that typical unilateral to bilateral spread.
And the treatment is straightforward.
Pretty much. Antibiotic drops or ointment. And strict hygiene warm compresses to gently clear the crusts. Lots of hand washing.
Okay. Scenario 2. A 7-year-old has red eyes, but they are super watery, like tears are just streaming down their face. They also have a runny nose and maybe some swollen glands you can feel in their neck lymphadenopathy.
That's your viral conjunctivitis. The key words are watery discharge and the association with a cold or an upper respiratory infection. Those swollen lymph nodes are also a classic viral sign, specifically the preauricular nodes right in front of the ear.
And the treatment for that?
Symptomatic relief only. Cool or warm, compresses, whatever feels better. No antibiotics, they won't touch a virus, just has to run its course, which can be, 7 to 14 days. but it's highly, highly contagious. They need to be kept home from school until the drainage stops.
Got it. Scenario 3. A 10-year-old comes in rubbing their eyes like crazy. They are red, they're puffy and watery. He says they itch really, really bad, and it's both eyes at the same time.
That is allergic conjunctivitis. The number one key word is itching. Intense itching or pruritus. Bacterial and viral might burn or feel gritty, but that intense, can't stop rubbing it itch is almost always allergy.
Anything else?
Yeah, often you'll see cobblestoning of the inner eyelid if you ever did. And it's usually bilateral from the start. Treatment there is antihistamines, oral or drops, and avoiding the allergen if you can.
Now, there is a can't-miss safety point here regarding medication. I saw a big warning in the notes about steroids.
Yes. This is a massive exam prep and a huge clinical safety issue. Do not use corticosteroids in the eye unless you are an ophthalmologist.
Why is that? I mean, steroids reduce inflammation, right? Seems like it would help.
They do, but they also suppress the local immune response. And if that child actually has a herpes simplex viral infection in their eye, which can look a lot like regular viral conjunctivitis at first, and you give them steroids, you are pouring gasoline on a fire.
Wow.
It can cause the virus to just explode, leading to corneal scarring and permanent blindness. So simple antibiotic drops or antihistamines are fine for primary care, but you stay away from the steroids unless you're absolutely sure what you're treating.
That is terrifying. And a great exam point. Okay, practical nursing skill time. Administering eye drops to a toddler. Have you ever tried to do this? It's like wrestling an alligator.
It is, and the natural instinct is to try to pry their eyelids open while they're screaming, but you risk poking them in the eye and you traumatize everyone involved. It doesn't work.
So what's the trick? What do the sources recommend?
The sources suggest a very clever physics-based technique. You have the child lie down flat. If they are fighting and squeezing their eyes shut, that's fine. Let them keep them closed.
Okay.
You then place the prescribed drop in the inner corner of the closed eye, the nasal campus, right in that little well.
So just right on the skin there.
Right in that little pocket at the corner of the eye.
Mm-hmm.
Then when the child eventually opens their eye, even for a split second to check if you're still there, gravity pulls the drop right into the conjunctival sac. It's so much less traumatic, it helps build trust, and it actually gets the medication where it needs to go.
That is a pro tip. I love that. Okay, let's move to topic 3. Visual development and structural disorders. We touched on this in the anatomy section. The idea that the brain will literally turn off a bad eye. Let's dig into strabismus.
Strabismus is just the medical term for misalignment of the eyes. So one eye looks straight ahead while the other turns in. That's esotropia, or turns out that's exotropia.
And this is normal for newborns for a little while, right?
For the very first few months, up to about 3 or 4 months old, intermittent crossing is pretty common. The ocular muscles are just weak and uncoordinated. But the text is clear. If it persists past 4 months, or if it is a constant fixed deviation at any age, it needs a referral.
So how do we test for this in the clinic? I see the corneal light reflex mentioned everywhere.
This is the Hirschberg test. It's so simple and so effective. You shine a pen light at the bridge of the child's nose from a little distance. You then look at the reflection of that light in their pupils.
And what are you looking for?
It should be in the exact same spot on both eyes, like at 12 o'clock on both pupils or 2 o'clock on both pupils.
Symmetrical. And if it's asymmetrical?
If the reflection is in the center of one pupil and maybe on the edge of the pupil in the other eye, that other eye is misaligned, that's a positive Hirschberg test. That's strabismus.
And then there is the cover test. This detects the lazy component, the amblyopia.
It confirms the strabismus. This is the next step. You have the child focus on an object. You cover their good eye, the one that's looking straight at you. Then you watch the other eye, the bad eye.
And what will it do?
If that bad eye suddenly moves to pick up fixation and focus on you when the good eye is covered, that means it was drifting before. It confirms the misalignment.
So we have the diagnosis. Now we have to treat it to prevent amblyopia. And the main treatment is patching. But this is the part that always confuses students. Which eye do we patch?
This is a classic exam question. You patch the healthy eye, the good eye, the one that sees well.
That feels so mean. You're taking away their clear vision.
It does feel mean. And parents hate it. But you have to think of it like strength training. If you have a weak left arm and a strong right arm and you want to strengthen the left one, you have to stop using the right one.
Okay, that's a good analogy.
If you don't patch the good eye, the brain will just continue to rely on it and ignore the weak one. You have to force the issue. You have to make the brain use that lazy eye's neural pathway.
And the text mentions compliance is a huge issue, I can imagine.
Incredibly hard. Imagine you were 3 years old. and someone covers your good eye. Now you can't see well. You feel vulnerable, clumsy. You're going to rip that patch right off.
So what's the nursing role there?
A lot of parent education on the psychology of it. Use pirate patches, create reward charts, let them decorate their patches, or do the patching during high-value screen time because they're motivated to focus and might forget it's on.
And how long do they typically have to do it for?
It varies, but usually it's for 2 to 6 hours a day. It doesn't necessarily have to be 24/7, which makes it a bit more manageable for families.
Now, there is one visual finding that is an absolute drop-everything emergency. We have to talk about leukocoria.
Yes. This is a can't-miss red flag. When you shine that light for the red reflex, like when you get red eye in a photograph, that's normal. You should see a reddish-orange reflection from the retina.
And if you don't, if you see something else.
If you see a white pupil, or what's sometimes called a cat's eye reflex, that is leukocoria.
And what does that mean? What's the differential for that?
It means something is blocking the light from hitting the retina, or the light is reflecting off a mass. In kids, the two big terrifying fears are a congenital cataract or retinoblastoma.
Retinoblastoma is a cancer.
Yes, a malignant tumor of the retina. It is life-threatening if it metastasizes to the optic nerve and the brain. A cataract, while not cancer, is a vision emergency because it's completely blocking the light and will cause profound, irreversible amblyopia if not removed.
So the bottom line is white pupil, immediate referral to ophthalmology.
Do not pass go. Do not wait. It's an emergency. Got it. White is bad. Red is good. Now, let's quickly touch on retinopathy of prematurity, or ROP. This is a very specific condition for the NICU population.
Correct. When a baby is born very premature, their retinal blood vessels aren't finished growing yet. They are fragile. If we have to give them high concentrations of oxygen to survive, or if their oxygen levels are unstable swinging up and down, it can cause those delicate vessels to grow wildly and then spasm.
And that leads to scarring.
Yes, it creates scar tissue that can pull on the retina. In the worst cases, it causes a retinal detachment and blindness. This is actually why Stevie Wonder is blind. It was ROP from the 1950s before we understood oxygen toxicity.
So oxygen is a drug.
Oxygen is absolutely a drug with a narrow therapeutic window and significant toxicity. The exam point here is knowing the risk factors, very low birth weight, early gestational age, and the duration and concentration of supplemental oxygen. We have to titrate oxygen so carefully in preemies.
Okay, let's slide into our last topic in this section. Topic 4, eye trauma, the ouch section. Kids are clumsy, they play with sticks, things happen. Trauma is surprisingly common. And the interventions are very specific and very testable.
Let's do the need to know for the big ones. A simple foreign body, sand or dirt in the eye.
First rule, do not rub. Rubbing is like taking sandpaper to the cornea. You irrigate with saline. You can try to invert the eyelid, flip it up like a hood if you can, to see if you can sweep it out with a moist cotton swab.
Okay. What about a chemical injury, like a kid gets into the cleaning supplies?
Irrigate, irrigate, irrigate. That's the only answer. Copious amounts of water or saline immediately. Don't wait to get to the ER to start flushing. Time is vision. You flush for at least 15-20 minutes holding the eye open.
And the big one, a penetrating injury. The kid who was running with a pencil and fell, the pencil is now sticking out of the eye.
Never remove the object. That is the golden rule. All caps, bold, underlined. If you pull it out, you might pull the contents of the eye out with it. The vitreous humor. Or you could cause a massive, uncontrollable bleed.
So what do you do instead? You can't just leave it.
You stabilize the object, you build a little fort around it with gauze rolls, or you take a paper cup, cut out the bottom, and place it over the eye and tape the cup down to the face so the object doesn't get bumped or moved.
And here's the other critical piece I saw in the notes, which is so easy to forget. You cover both eyes, even the uninjured one.
Yes. This is counterintuitive, but absolutely vital.
Why both, if only one is hurt?
It's because of consensual movement. Our eyes are wired to move together. If the child looks around the room with their good eye to see mom or the nurse, the injured eye will move too, in sync.
And that movement could cause more damage.
Way more damage if there's a foreign object lodged inside. By covering both eyes, you stop them from looking around. It keeps the injured eye as still as possible.
That is such a critical nursing intervention, but it totally changes the care plan. You've just blinded them temporarily. You have to talk to them constantly.
Exactly. You become their eyes. You have to narrate everything. I'm holding your hand now. We are moving the bed to the left. It requires a really high level of communication and reassurance.
All right, we have covered the systems. Now I want to bring it all back to the so what. Specifically regarding development, we talked about hearing loss, and speech delay. What about vision loss? What are the developmental red flags we should be looking for there?
Vision is how an infant learns about their environment before they can crawl or walk. If they can't see, they are isolated. They can't see the smile on their mother's face, so they don't learn to smile back socially. It impacts bonding.
So what are the specific red flags an exam might ask for, the concrete behaviors?
In an infant, does not fix and follow an object with their eyes by 3-4 months, does not make eye contact, has a dull, vacant stare, or, and this is a subtle one, does not imitate facial expression, like sticking out their tongue.
And for a toddler who can move around?
That's when you see them rubbing their eyes constantly, squinting a lot, bumping into objects.
Oh.
Or a big one is holding books or tablets inches from their face to see them.
And how does this manifest socially or behaviorally?
It can look like a behavior problem. This is the synthesis piece that's so important. A child who is labeled as clumsy or aggressive or withdrawn might just be terrified because they can't see who is coming at them. They might self-stimulate, like rocking or poking their eyes, because they aren't getting external visual stimulation, so they're trying to create their own.
So what's a key nursing intervention for a visually impaired child who's hospitalized?
Promote independence, but provide a safe, predictable environment. You always announce yourself when you enter the room. Don't just touch them. That's terrifying. You describe the room layout. Your chair is to your left. And for eating, you use the clock method.
The clock method is a classic NCLEX question.
It is, because it's so practical. Your peas are at 3 o'clock on your plate. Your chicken is at 6 o'clock. It allows the child to feed themselves. It preserves their dignity and fosters independence, which is the ultimate goal of pediatric nursing.
Okay, we are entering the final stretch, Section C. The cross-linking and synthesis. We have thrown a ton of information out there. Let's recap the red flag differentiators that will help our listeners on an exam or in triage.
Let's simplify it. Let's boil it down into 3 main categories of differentiation. If you remember nothing else from this deep dive, remember these 3 distinct patterns.
Go for it.
1, pain differentiation. It's all about the location and type of pain.
Okay.
If it hurts when you touch the outside of the ear, the tragus or the pinna, it is otitis externa, full stop. If it hurts deep inside, it disrupts their sleep and they are pulling at the ear, that's your acute otitis media. And if it doesn't really hurt but feels full or is popping, that's otitis media with effusion.
Perfect. What's number 2?
2, discharge differentiation. This is for the eyes.
Got it.
Pus or thick, purulent discharge equals bacterial conjunctivitis. Watery discharge plus intense itching equals allergic conjunctivitis. And watery discharge plus a cold and swollen lymph nodes equals viral conjunctivitis.
Clear and simple. And the 3rd?
3, reflex differentiation. This is for the vision screening. An asymmetrical corneal light reflex, where the light is centered in one pupil and off-center in the other, equals strabismus. And a white reflex, leukocoria, equals a potential cataract or retinoblastoma, which is an emergency.
That is the cheat sheet right there. That is the Pareto 80-20 of pediatric sensory assessment.
And one final safe practice consensus point, just to hammer it home, regarding antibiotics for ears. If sources seem to disagree, always stick to the AAP guideline. Watchful waiting is safe and preferred for healthy kids over 6 months with mild to moderate AOM. But under 6 months or severe symptoms, always get treated.
Perfect.
You know, one thing I want to add before we close, we talked about the anatomy being destiny, that horizontal tube, but we can influence that destiny with prevention. The sources highlight 3 really key things parents can do.
Okay, let's hear them.
First, breastfeeding. The sources are clear on this. It confers paternal antibodies, and the sucking mechanism at the breast is better for eustachian tube function than a bottle.
Makes sense.
Second, no smoking. This is huge.
Right.
Secondhand smoke paralyzes the cilia in the eustachian tube. Those little hairs are supposed to sweep fluid out. If they're paralyzed, the fluid just sits there and infection breeds. Passive smoke is a massive risk factor for recurrent ear infections.
And the 3rd?
Feeding position. Never, ever prop a bottle and let a baby drink lying flat on their back. The milk or formula can pool in the nasopharynx and flow right up that horizontal highway into the ear. It's basically a direct injection of sugar water into the middle ear.
Which bacteria love?
Which bacteria absolutely love. Feed them upright.
Those are 3 massive parent education points that can prevent the whole problem before it even starts. All right, this has been an incredibly comprehensive deep dive. We have unpacked the anatomy, the infections, the critical visual development, and the trauma.
We have definitely covered a lot of ground.
As we sign off, I just want to leave our listeners with a thought. We spend so much time in nursing school memorizing the drugs, the amoxicillin, the drops, the dosage calculations, and those are important, of course.
Oh, there they are.
But in pediatrics, the medical fix is often the easy part. The hard part is understanding the why behind the development. Why does this matter to this kid at this age?
Absolutely. The provocative thought I'd leave you with is this. A child's sensory system is their interface with humanity. It's how they connect, it's how they learn, it's how they love. If that interface is broken, if they have cloudy vision or muffled hearing, they aren't just sick.
They're isolated.
They are lonely. They are confused. A behavioral outburst in a classroom might not be ADHD. It might be a kid who hasn't heard a clear sentence in 6 months because of chronic fluid in their ears.
So when you're assessing that kid, look deeper. Don't just look at the eardrum. Look at the child behind the eardrum.
Exactly. That's the art of pediatric nursing.
Keep your eyes open and your ears to the ground. Thanks for listening to The Deep Dive. We'll see you next time.
Take care.